afternoon. My name is Cassie Iverson. I'm the Assistant Director of Long-Term Care for the region. And I'm a co-lead on, my boss is here, co-lead for RPIW number 47. So our team, we are the File Me Now, Thank You Later. And I'd like to acknowledge and thank one of our team members, Sonia Workentine, who was not able to be with us today, but she put a huge amount of work and contributed a huge amount to our RPIW. So thank you to Sonia. So our project, looking at client information that's in the mental health outpatient file room, getting into the client chart 100% of the time. So really ensuring that we have safe patients by ensuring good information flow, ensuring that the information is there to provide safe patient care at all times, and just maintaining current and relevant information just to prevent patient safety incidents due to missing or delayed info. So the chart that does exist, it is a paper-driven chart. There are multiple sources of information that comprise that chart. And some of the more important ones are lab results, prescriptions, notes from clinicians, psychiatrists, nurses. And really those loose pieces of information, they need to get into that patient chart. There have been client safety instances. There were 108 times noted where the most recent note was not on the chart. Other times, the most recent prescription was not on the chart, leading to the patient receiving the wrong prescription. Other factors that play into this, sometimes the chart's not available in the file room for the information to get onto. There could be 1,250 charts that need to be signed in and out a month, and one MOA in the file room could handle 85 charts, approximately on average 165 pieces of loose filing, and have to create new charts on top of that. So our target sheet, so the targets related to space and inventory, we address those through our 5S, and you'll hear from Lori later about our 5S evaluation. The walking distance was related to the MOA in the file room having to walk to answer the phone. And Tina will be speaking to that target a little later. Part travel distance. So the chart was being signed in and out and having to get to the clinician in order for them to sign their note. And we'll be having Lisa speak to that target as well. We looked at one of our metrics as being the loose filing. So right now, 100% of the loose filing, or the backlog that exists, is not getting into the chart, and looking at reducing that. Productivity gain, right now it was taking about 8 minutes to process one chart, and Lori will talk about that more later. And we were looking at reducing our setup and cycle time just to increase capacity to get that loose filing into the chart. Our value stream now. So this was the work of the file room MOA, processing a chart. So a chart that was brought back into the file room had to be signed in, shelved, and then when a chart was requested, it had to be pulled, it had to be signed out, it had to get to the provider that required it, which is the top row. Underneath that, there was still those patient charts to be made, and there was still existing loose filing that needed to get into those charts as well. So as you can see, we have a lot of Kaizen bursts, and those were related to waste or interruptions that were impeding the flow of this process. And you're going to hear about the great improvement work that was done to reduce or eliminate those wastes or interruptions so that we could get to a good process flow and just be able to do all of today's work today. Our takt time, so there were actually 2 takt times that we calculated. One was loose filing. So it was determined that one piece of loose filing would need to get into the chart every 2.5 minutes. And one patient chart needed to leave the process every 5 minutes.
I'm Lisa. I'm one of the clinicians at Outpatient Mental Health. One of the targets that we identified was the clinician notes that were returning from transcription for signing. Under the previous system, the paper would come in, the chart would be pulled, signed out, transported to the mailroom for distribution to the clinicians for signing. They would sign it, return it into a bucket that was then later returned to the file room and had to be signed back in and filed. So we looked at a number of ideas for this difficulty, and we were able to trial 2 this week. One was for clinicians who type their own notes to use their e-signature, which completely eliminated the need for the clinician to get that note back. And the other idea was for notes that either don't have, for clinicians without an e-signature or for those who dictate, was for that piece of paper to go directly into the clinician mailbox for signing, and then for that to be returned. And that eliminated the chart needing to travel. It significantly reduced how much time the MOA was processing paper. It also kept the chart available for emergencies or for other filing that may need to go onto the chart. So when we trialed it, we put up a sign reminding clinicians to sign their note, and then we created a work standard that encourages clinicians to take no more than 5 days to sign that note and return.
Hi, my name is Allison Gillespie. I'm a physical therapist with the Health Region, and I was a participant in this project as part of my Lean Leader training. So our team was looking at the amount and the flow of managing the loose filing. And we basically approached that 2 different ways. One was to look at the opportunities to perform the loose filing during the day, and the second was just to reduce the amount of volume of things that had to be loose filed. So this is our new process that the file clerk MOA will be following in order to have more opportunities to loose file during the day. So previously what had happened, although it was really important, it was one of the last things that got done when all of the other jobs she had to do got done. And so it was kind of there one point during the day when everything else was done, and it led to a really significant backlog, which then just kind of spiraled and grew and grew and grew, just like credit card debt, kind of getting out of hand. So what we did is if you look at this, you'll see there's several mentions of loose charting spread throughout the day, so that she can be doing that as she's pulling charts for other tasks and duties, so that she's bringing down smaller batches and getting to it frequently throughout the day rather than leaving it to the end of the day. So that was how we designed her new flow, and we have a work standard that we've designed that can be used both by the file clerk MOAs and any of the other MOAs who might be covering that on a more casual basis to cover. So the other thing we looked at is when we did that originally, it took her about 7 minutes, 19 seconds to get onto the chart. And if we look at that on the standard work combo sheet, we can see that isn't meeting her tack time and telling us why we had so much backlog of loose filing. So with our new system, you see we brought it down to just over 6 minutes. And if we look at the standard work combo sheet again, we're still a little bit over that tack time, but that was really based on a first run of our new system, and we think as she gets used to it and feels comfortable that that's going to come down and meet our tack time, so there's actually the time in the day for her to do the loose filing she gets. And then the percent loads just show that in a different way, how her different tasks have been shortened and impacted by the new changes and the new flow to bring us down a little bit closer to meeting that tack time and giving her the time to get the loose filing done. So the other piece of our work was to just reduce the volume of papers of loose filing she had to do. If you look down there, one of our big sources of loose filing was our mental health nursing notes. Because they were going and writing things by hand, it was just a higher volume of paper. So what we wanted to do was see what we could do to decrease that volume. And this was actually identified before our team got there. This was by one of the staff members in mental health nursing. And they had actually developed a process before we arrived that is basically going to result in all of those blue notes that you can see in those stacks no longer coming to the filing room. So the file clerk won't have to deal with them at all. So you can see when that blue notes are stacked up against everything else that comes in loose filing, they're a pretty significant contributor to the workload she was having to work through in the past. So those are no longer going to be there. As well as from transcription, we're very accommodating and allowed us, before they were sending everything back that they transcribed, and the file clerk MOA was having to sort through things that didn't even go onto the charts and send them to where they needed to go. So transcription has agreed to pull out those particular items and kind of put them together so that they never hit the file room. They can be put onto the desk of the person who requires them without having to sort them out. So those two access will decrease a lot of the volume of loose filing that you have to do throughout the day.
Okay, I'm not going to be as wordy as she was, so. My name is Eva. My name is Eva Taitula, and I'm the MOA at the Mental Health Outpatients Chart Room, File Room, whatever you want to call it. This is my experience. This is my first experience being part of a RPIW, and what a fantastic team to have that experience with. Thank you, ladies. Our challenge was to make the chart sign-in and sign-out process more efficient and less time-consuming. Problem: charts are tracked manually using recipe cards with no way to track record of access. We now have in place electronic sign-in, sign-out. There is a work standard in place for the sign-in process and the sign-out process. These processes will be implemented February 23rd. Next problem: charts leaving the staff room not being signed out. Now visual cues are in place in the MOA area, mail room, and on the wall by the door of the chart room. Multiple training skills schedules for MOAs will begin February 23rd. Next problem: file requests from psychiatry and clinicians were being handled with a paper system. To eliminate interruptions in MOA work in the file room, the process was put in place was an electronic file request with exceptions as stated in the work standard, which will be submitted to an electronic mailbox. This mailbox will be checked every 2 hours. There is a work standard in place for psychiatry and clinicians. These processes and multiple training skills schedule for psychiatry clinicians and MOAs will be implemented February 23rd.
Hello, I'm Tina, the happy volunteer from the volunteer department here at the hospital. I had the privilege to be the patient rep for RPIW number 47 and worked with the team that looked for solutions with much help from Eva, the queen of the file room. The place is super busy. There's rows and rows of files from floor to ceiling, and phone interruptions proved an obstacle. Eva would drop everything she was doing, walk an extra 36 feet from the filing area just to get to the phone. We came up with the idea for Eva to be supplied with a headset. Phone calls can be answered on the spot, and the extra waste steps can be avoided. Less walking to her desk means promptness and efficiency can be maximized, making it a plus for clinicians and patients as well. In the end, we have a very, very happy MOA section as we all celebrate this positive outcome of this particular aspect of RPIW number 47, fondly known as File Me Now, Thank Me Later.
Good afternoon, everyone. My name is Lori Anderson. I am from Heartland Health Region, and I've had the honor and privilege of spending the last few weeks here doing my co-lead role, and will now be finished my leader certification, hopefully, right? Right. So I just wanted to share with you, Kathy and I in prep week came down and did a quick little 5S in the MOI file room. Here's a pre-picture, and here is our post. we were able to get a lot of things cleaned off and free up some space for them. So our pre-score was a 1.1 and our post was a 2.9. We developed some standard work to support them in maintenance of this FIDUS, as well as an audit. I think currently they already have done, yes, 2 audits, all of them looking really great, so we're hoping that works out for them. Earlier, Kathy had talked about the many Kaizen opportunities that we found within this process. We were able to knock off 12 of the 26 that we had identified. Many of the remaining ones are kind of maybe a little bit out of our scope and involve other departments. Because our work is not siloed and there's many different departments that kind of feed into this work, there's opportunity for improvement that we just weren't able to address. So our target progress report sheet. So yeah, this was a lot of work. We set some very high targets for this team to meet, and they met the challenge with some exceptional ideas and some really hard work over the week. I will speak to the walking distance. So as Tina mentioned, with the headset, we were able to reduce the walking distance by 100%. We looked at our part travel distance, as Lisa referred to, and we were talking about the chart being checked out of the room to get the clinician notes signed. We eliminated that procedure, so now there is a 100% reduction in that. We also looked at quality. So for us, our quality metrics were number of interruptions. We did reduce, the top one is the reduction that we did see will be those phone call requests for charts. We do have a chart retrieval, electronic chart retrieval that will hopefully address some of those. And then we looked at the percent of loose filing that was left at the end of the day. So our goal, of course, was to have 100% of today's work done today. Our audit yesterday showed that of the 145 pieces of loose filing that came in, there was only, I believe, 27 pieces left. And I think 14 of those were because there was no chart in the room, so a clinician had the chart out. And the other 12, there was no chart available, so one had to be made. So they did a really great job of that. Our key goals were really to increase the productivity and the capacity for that MOA file clerk, so that she could manage the work that was coming in. So we made some big gains in doing that part. Again, as to what Allison spoke to, the reduction of the actual incoming filing made a significant impact on that. So our newspaper, yeah. So we have a few things outstanding. We won't go through them all, but mainly the focus around, they mainly focus around the full implementation of the electronic sign-in, sign-out system and the electronic chart request. So because we're transitioning from a paper-based into an electronic system, there were some actions required still by IT, and then training for all the staff once IT is done their piece. It was something we just couldn't rush through, and so yes, there is some outstanding work to do. There's also pieces of around client information that comes into that MOA file room that is real. There's no clear direction on what should happen to it. It's kind of unknown. There's random pieces. So there's some work that we will be asking managers to support us with developing some standards around what needs to happen with that stuff. So in summary, we did a lot of work. They have a new electronic chart sign-in, sign-out system. There's a new electronic chart request system for mental health outpatient staff. So not only does that reduce the interruptions for the MOA, but it certainly reduces any travel time for clinicians. They used to have to come downstairs and write at the registration desk whether or not they needed a chart. So now they can just do it from their desk. There's a new process for clinicians to sign their notes without the MOA having to sign a chart out for them. That means the chart's in the room and available to have loose filing filed into it. We looked at increasing the capacity to do the work today by driving out the waste, and we did a significant job at that. You guys did a great job. And our little bonus was the headset implementation to reduce MOA walking and to help save some time there. So of course we have many people to thank. like I said earlier, this is not, healthcare is not a siloed system. We have lots of people that we depend on to make the patient's experience as safe as it can be. So, thank you to all of these people and to this great team to work with. It was a fantastic week. So, and to our KPO support. Yeah. So thank you very much.